Welcome to AETCM, the emergency medicine channel. Today we are discussing about hypercalcemia, the major clinical features and management of hypercalcemia in emergency room we'll discuss. Calcium is an essential mineral. It is required for bone formation and some neuromuscular function it is required. Around 99% of the body calcium is inside the body, but other 1% is in the extracellular fluid. That is only we are measuring and we are finding out whether it is high or low. Nearly 50% of the serum calcium is ionized. That means it's free. Whereas other 40% is bound to albumin. So it has got a strong relationship with albumin levels in the body. And anions such as phosphate. So phosphate and albumin levels may alter the serum calcium. Calcium balance is regulated mainly by two important hormones. One is parathyroid hormones, another one is vitamin D. Parathyroid hormone stimulates bone resorption and promotes conversion of vitamin D to calcitriol. So I am not going to the physiology of these hormones. We'll just discuss the clinical features. Now you can see here low concentration of calcium in the blood due to some reason. If the calcium is low, we are not taking adequate calcium in our diet. What happens is parathyroid hormone will be released. Then it acts in the bone and calcium from bone will come out to the blood. In kidneys, there will be decreased loss of calcium in the urine. If calcium is high, kidney will remove it. If calcium is low, it will preserve it. Then vitamin D will be produced in the kidney. Active form of vitamin D will be produced, and from intestine that will stimulate the absorption of calcium and maintain the calcium levels in our blood. So this is the basic physiology of calcium regulation in our body. Now I am talking about corrected calcium. This is very important because many of our patients who are admitted in emergency room, when we check the calcium, it may be slightly low, but we never see the albumin levels in that patient. We have to see the albumin levels and correct the calcium what is available in the lab investigation, and we have to correct it, and then we'll get the corrected calcium or real calcium. So we can calculate it like this: serum calcium plus 4, that is a normal albumin level, 4 minus serum albumin, that will give the deficit of in the albumin, into 0.8, that will give the corrected calcium. That should be done only if there is a hypoalbuminemia. The plasma calcium concentration falls by 0.8 milligram per deciliter for every 1 gram per deciliter fall in the plasma albumin concentration. So that is very important. We have to calculate the corrected calcium in hypoalbuminemia patient. So hyperalbuminemia can increase the serum calcium level also. So hypoalbuminemia falsely decreases the calcium. Like that, hyperalbuminemia can falsely increase the serum calcium. Now hypercalcemia is defined as serum calcium more than 10.2. Some labs it may slightly vary. With normal albumin should be normal. If it is abnormal or low, we have to calculate it. Corrected calcium should be calculated. Among all causes of hypercalcemia, the most important cause is primary hyperparathyroidism. But what we see in our routine practice in a tertiary care center, it is mostly related to malignancies like bone metastasis or multiple myeloma. These are the common causes of hypercalcemia in routine emergency room. But hyperparathyroidism is one of the major cause for hypercalcemia all around the world. And when we are talking about OPD patients, that may be the most common, but in emergency room, the most common cause is always malignancy, especially multiple myeloma. Patients with hypercalcemia due to malignancy, they have very high levels of calcium concentration comparing with hyperparathyroidism, and they are resistant to treatment also. Recurrent and high calcium levels are very common with the patients who is having malignancy related hypercalcemia. That is the main clue in clinical clue to make a diagnosis. Very high calcium levels, very symptomatic patient, resistant to treat. All these things are features of malignancy related hypercalcemia, whereas parathyroid related hypercalcemia is very easy to treat. Pseudohypercalcemia is patient with have hyperalbuminemia, like we have discussed. Hypoalbuminemia reduces calcium falsely. Here hyperalbuminemia increases the total serum calcium, especially in multiple myeloma. But what we should remember is we have to calculate whether it is falsely high, but most of the multiple myeloma patients itself, the calcium in the multiple myeloma itself will be very high. So it may produce some confusion, but however, patients who is having high calcium in multiple myeloma should be treated as hypercalcemia itself. Now we can see the causes for hypercalcemia. You can remember a mnemonic like this: chimpanzees. Calcium excess, administration of high levels of calcium, especially IV calcium. Hyperparathyroidism, that is one of the most common cause. Immobilization, like prolonged bed rest, can produce sometimes hypercalcemia. Multiple myeloma, that is most important cause. Milk alkali syndrome, parathyroid adenoma, aluminum intoxication, neoplasm, which infiltrates to the bone, or paraneoplastic syndrome, like parathyroid related hormone production, that is a paraneoplastic syndrome. Solinger-Ellison syndrome, excessive vitamin D intake, that is nowadays it is common because many patients have very low vitamin and they start taking vitamin D, and if they don't stop after 2 to 3 months, then many patients can develop hypervitaminosis. Excess vitamin A also seen in some children. Sarcoidosis, another important cause. There also you can get elevated calcium. So all other causes are given on the opposite side. Same thing, but to remember this, you can remember as chimpanzees. Now symptoms of hypercalcemia you can remember like bones, stones, abdominal groans, psychic moans. Bones means patient will have severe bone pain. But patients who is having malignancy can have bone pain because of the metastatic lesion itself. But hyperparathyroidism also they can have bone pain. Kidney stones are common in patients who is having calcium phosphate crystals and calcium oxalate crystal infiltration to the kidneys. Groans means most of the patients will have constipation and abdominal pain. Moans means most of these patients will be depressed. They have lethargy, fatigue, confusion, anxiety, hallucination, irritability and all. Many patients are depressed and some patients will be hyperactive and irritable. So these are the clinical features of hypercalcemia. ECG is very important, that we'll discuss afterwards. ECG in hypercalcemia, both in hypercalcemia and hypocalcemia you can get ECG changes. I am discussing about hypercalcemia here, that's why I am discussing the changes in high calcium. Short QT interval is very important. Some patients with very high calcium levels, they develop ventricular irritability, ventricular tachycardia, ventricular fibrillation and cardiac arrest. So hypercalcemia and hypocalcemia both are bad for heart, both can produce arrhythmias. Here short QT interval can produce and then the patient develops ventricular arrhythmia. Another important finding you can observe in this type of patients is a Osborne wave. This wave is waves can also be seen in patient who is having hypothermia. So that is not a very classical finding seen in hypercalcemia. But other finding like short QT interval is very important. So whenever you see a hypercalcemia patient, always remember to take a ECG and look for the QT interval in that patient. Now the blood investigation, routine blood investigation after getting a high calcium level, always ask for a serum PTH. Remember PTH single value may not be sufficient in many patients because lab errors are very common in serum PTH levels. If you get a doubtful report, you may have to repeat the PTH levels. If PTH is normal or elevated with elevated urinary calcium, hyperparathyroidism. So you can get the diagnosis PTH is elevated urinary calcium. Low urinary calcium is familial hypercalcemia. PTH is low means suspected malignancy. So whenever you have a hypercalcemia patient, always check the PTH. If PTH is high, then it is mostly because of hyperparathyroidism. If PTH is low, then we have differential diagnosis, like patient can have malignancy, patient can have bone lesions, patient can have multiple myeloma, patient can have sarcoidosis. So many differential diagnoses can be there if PTH is low. So the most important investigation in hypercalcemia is PTH. Whether the high calcium is related to high PTH or not. That is very important. Then serum phosphate also can be done to know whether the patient is having primary hyperparathyroidism or tertiary hyperparathyroidism. So these two investigations must be done in all patients. If there is no elevated PTH, then you have to investigate for malignancy. So basic malignancy investigations are take a skull X-ray lateral view, take a chest X-ray, see any mediastinal lymph nodes are there, like sarcoidosis can present with mediastinal lymph nodes. Take an X-ray, again see the ribs for infiltrative lesions. Then take a X-ray of spine, see any punched out lesions are there. So all these things are important. We are investigating for malignancy, ultrasound abdomen, ultrasound breast, ultrasound prostate. All these things can be done. So multiple myeloma should be investigated if PTH is low. So in that, so many other investigations will come. But the basic thing is, if bone lesions are there, if alkaline phosphatase is normal, if there is a bone lesion, hypercalcemia is there, alkaline phosphatase are normal, then we have to suspect multiple myeloma. If alkaline phosphatase is elevated, then we have to think about a infiltrative disease like malignancy, infiltrative malignancies of bone. So that is very, very important. Alkaline phosphatase is a very important investigation when there is hypercalcemia and bone lesion. So remember, multiple myeloma will have a high calcium level, hypercalcemia, normal parathyroid hormone because it is not related to parathyroid hormone. Then alkaline phosphatase is normal in multiple myeloma. It is elevated in other types of bone metastasis. Then in malignancies like lung malignancy and all, parathyroid related protein can also be investigated if facilities are available. In that, parathyroid hormone will be normal. Now we'll discuss about patients who is having hypercalcemia, how to manage in emergency room. If patients are asymptomatic, no treatment is required. We can investigate the patient. Most of these patients may require higher oral water intake. That is very, very important. Otherwise, patient can develop slowly other problems because of hypercalcemia, renal failure and all can develop. So increased water intake is very important in patients who is having asymptomatic hypercalcemia, and they should be investigated thoroughly to find out the reasons for hypercalcemia. Rehydration, that is very, very important. Most of the patients who is having high calcium, especially when the calcium levels are more than 14, they can have severe dehydration and renal failure. We can give IV fluids. Around 10 liters per day is required. 0.9 saline, that is normal saline, plus furosemide, that should be given. Diuretics increases urinary calcium excretion via inhibition of calcium reabsorption in the loop of Henle. That is very important. So you give high amount of water, so dehydration will be corrected. Then we have to enhance the urine output, add diuretics after correcting the fluid deficit. Okay, so that is very important. So IV normal saline with Lasix is very, very important in the management of symptomatic hypercalcemia or hypercalcemia with ECG changes. Now, bisphosphonate is another important treatment we routinely give in osteoporosis, but here we are giving for hypercalcemia. Osteoporosis we give higher dose like 5 mg we give. Here 4 mg only we give. If renal failure is not there, we can safely give zoledronic acid. If renal failure is there, better to avoid this drug, or according to the renal creatinine clearance, we have to adjust the dose. So that inhibits the bone resorption via interface with osteoclast recruitment and function. So especially who is having hyperparathyroidism and malignancy, this drug can be given. But if there is renal failure, we should be very careful. Zoledronic acid 4 mg in 100 ml normal saline IV infusion over 15 minutes. Pamidronate is an alternative. Etidronate is another drug which is available. So these drugs can be tried. Dinosumab is a human monoclonal antibody which can be given if there is a resistant hypercalcemia to bisphosphonate therapy. It can be given as a dose of 120 mg subcutaneously every 4 weeks. So malignancy related or severe hyperparathyroidism, if there is hypercalcemia persisting even after good dose of bisphosphonate therapy, then we can try Dinosumab. Now, steroids are not indicated in the initial phase of hypercalcemia. The action of steroids, they decrease the intestinal calcium absorption and increases urinary calcium excretion. You may be knowing that when the patient is having some disease and patient is on chronic steroid therapy, they are developing osteoporosis. That's because the patient is not getting adequate calcium from the intestine. So they block the intestinal absorption of calcium. So it is mainly used in sarcoidosis. This is the best treatment option in sarcoidosis because steroids can reduce the activity of sarcoidosis, and it can reduce the calcium absorption and reduce the hypercalcemia in patients. Multiple myeloma also, this can be given in patients who is having hypercalcemia with multiple myeloma. If your diagnosis is confirmed, then we can start steroids. Before diagnosing like both in sarcoidosis and multiple myeloma, never give steroids because it can mask most of the findings, especially in sarcoidosis and some amount in multiple myeloma. The active inflammation will come down, so we may not get a good result for diagnosis. Vitamin D intoxication, vitamin A intoxication also we can give this. The usual dose is IV hydrocortisone 100 to 300 mg daily or oral prednisolone 1 to 2 mg per kg body can be given. Remember, steroids should not be used as a first line therapy in hypercalcemia because it can mask most of the diagnosis, and it is best used in patients who is having sarcoidosis. Salmon calcitonin or calcitonin injection infusion 4 to 8 international unit per kg IM 6th hourly can be given. It reduces the calcium level by increasing renal calcium excretion by decreasing bone reabsorption. So it can also reduce the serum calcium. Nasal calcitonin, which is used in like metabolic bone disorders or osteoporosis, should not be used here. That will not have any action. You have to give subcutaneous injections or IM injections. So action will last only for 48 hours. So you may have to give repeated doses. Repeated doses can produce tachyphylaxis or resistance to the action. Now this is the complete evaluation slide for hypercalcemia. Whether they are symptomatic, asymptomatic, how to go ahead, what are the drugs used. All these things are explained in this chart beautifully. You can read this. Whatever I discussed in the previous slides is given here. Now the last treatment, if patients does not improve with your routine therapy, if the calcium is very high, patient is getting ECG changes even after regular therapy, or patient is not responding to your routine treatment, patient is symptomatic, more symptoms of hypercalcemia, then this patient must undergo dialysis. Especially if there is renal failure, we cannot use most of the drugs like bisphosphonates, high fluid or intake. All these things are cannot be used or used with caution, so we cannot use these drugs. So dialysis will be the best option in that type of patients. So we have discussed in detail about hypercalcemia and its management in emergency room. We have discussed what are the causes for hypercalcemia, how to investigate, how to treat. Remember, hypercalcemia means most important investigation is parathyroid hormone. If they are negative, then you have to think about a bone lesion, especially metastatic lesions or multiple myeloma. And malignancy related hypercalcemia is resistant to routine treatment. They may require higher level of treatment like monoclonal antibodies or dialysis, something like that needed. And basically the disease should be treated. The basic primary disease should be treated, like multiple myeloma treatment will reduce the incidence of hypercalcemia. Thank you.